good day to everybody listening. My name's Martin Kiernan, and it's my great pleasure to host this teleclass. And we're very excited to have the WHO present to us today on the global situation of infection prevention and control and its impact on health, where we'll be also looking at cost effectiveness issues. We have two speakers for you, Professor Benedetta Allegranzi and Michele Cicchini. Now, what I'm going to do is introduce Benedetta briefly first, but if there's anybody on planet Earth who doesn't know her, I'm not sure it's going to be that useful. But anyway, if you're just visiting from another planet, Benedetta is a specialist in infectious diseases, tropical medicine, infection prevention and control, and hospital epidemiology. But she's the unit head of the WHO Global IPC unit and a joint professor at the Faculty of Medicine at the University of Geneva in Switzerland, where she's involved with research and the Global Health Institute. She's going to start off this session by giving us a comprehensive overview of the current global state of infection prevention and control, presenting some data about the status of the implementation of IPC programs, which is critical for us as we go forward in trying to prevent healthcare-associated infections and combating the major challenge of antimicrobial resistance. So, Benedetta, welcome. The stage is yours.
Thank you so much, Martin, for your very kind introduction. And thanks a lot to the Weber Training System and to Paul Weber for hosting myself and my dear colleague, Michele Cecchini from OECD, to go through together a number of pieces of data to understand what is the current global situation of IPC, but also of the burden of disease due to HAIs and its impact on health, but also on economies, which will be the part that my colleague Michele will go through after me. So if I can ask to move the next slide, please.
Benedetta, you should be able to move them yourself. Just use your right arrow.
Okay. It doesn't seem so. Sorry, there is an arrow. Yeah, that's so okay. Okay, apologies, but it was a bit slow on my screen. First of all, I just wanted to say my presentation will focus on data that you can find in the Global Report on IPC 2024 that was issued by WHO in November. And also next week, we will publish a new document, which is entitled The Case for Investment and Action in IPC, where we summarize some of the data that are already available in the global report. But in addition, we highlight aspects related to effectiveness of IPC interventions and also the return on investment in terms of economy and cost effectiveness and cost saving, which is the part that my colleague will present later. In general, when we want to make the investment case for infection prevention and control, like in other fields as well, it is useful to, first of all, highlight the harm and burden caused by this type of infections, in particular those acquired in healthcare, including the antimicrobial resistant ones. And to highlight what is the global situation of infection prevention and control in terms of what is done in countries to face the burden and to reduce it. And the third element, which is really important, is to highlight the impact of IPC interventions, as I said, in terms of improving health and also economics. So the first point I would like to tackle, going through some data that come from the global report, is to highlight the harm and burden caused by healthcare-associated infections. First of all, noting that the AMR burden is predominantly associated to healthcare, and recent data published in 2023 highlighted that 136 million hospital-associated antibiotic-resistant infections occur every year globally, according to an interesting study that was building upon reports, mainly prevalence studies from 99 countries. In addition, we also know recently that there are other reviews that were published in the same year that are documented within the global report, where it is clear that the prevalence of HAIs varies depending on the country and also the continent, from about 10% in the Americas and the Eastern Mediterranean regions to 27% in Africa. But it's also important to note that it is difficult to make comparisons among studies performed in different settings. Also, maybe even if they are all in this review prevalence studies, they may have used partially different methodologies. What is clear across all studies and also from previous report by WHO is that HAI frequency is significantly higher in low and middle income countries than in high income countries. And here are some images that also help us understand what is the impact in terms of burden of disease. According to studies performed and published by the European CDC some years ago, the first circle labeled A shows you that HAIs account for twice the burden of the other 32 infectious diseases combined that are surveyed by ECDC in terms of dailies, which means impact in terms of premature mortality and disabilities. Similarly, this burden, estimated in dailies, has an important impact on AMR. So what we know from ECDC regarding the European countries is that 75% of the burden in terms of premature mortality and disabilities associated with AMR is due to healthcare associated infections. The next slide confirms very remarkably this last piece of data which I mentioned from ECDC. According to OECD estimates published in this important report that is the latest that they published on AMR in 2023, where you can see, I've just told you that the burden according to ECDC of AMR is for 75% attributable or due to HAIs. In this graph, you can see that the share of AMR is due in terms of mortality to HAIs for its 73%. So very similar data, documented similar similar concepts, which therefore reinforce each other. According to the next slide, we go back to the concept of the spread of HAIs around the world with different prevalence data that you can see represented in this map. And I would like now to focus on the latest prevalence survey conducted and published by ECDC regarding the European continent. And go to the next slide where this is a different slide, but in the previous map you could appreciate that the prevalence of HAIs in European countries according to the latest ECDC survey is 8%. And this increases to about 20% in patients admitted to ICUs. In this graph, which is coming from a recent OECD and WHO study, which will be better explained by my colleague, who will provide a lot of more information on it. From this study here, we can appreciate also what is the variation of the impact of mortality due to HAIs according to different continents and also level of income. Here we are looking at annual mortality rates attributable to HAIs estimated in age-adjusted mortality per 100,000 persons. And from this graph, you can see, for example, that in basically in almost all regions, the burden is higher in low income and lower middle income countries. And the highest burden can be seen in the African continent, as well as also in low-income countries in the Eastern Mediterranean region, according to the WHO distribution of continents. I'm just waiting that the slide move. Apologies. It doesn't seem they do. Can I ask Paul? Okay. And going back to the situation in Europe, you can see that 1 in 14 hospital, and in this case, we are only talking about acute care hospitals, 1 in 14 patients, hospital patients acquire an infection. This corresponds to a prevalence of 7.1% of patients affected with at least one HAI, and it increases to 8%, as I was saying, when they are affected by more than one. And this corresponds in any given day to 93,000 patients affected by HAIs in Europe. You can also see that about 61% of these infections were microbiological documented by ECDC, and that according to the distribution of different pathogens, gram-negatives have been identified as the most frequent causes of HAIs, with E. coli, Klebsiella, and other Enterobacteriaceae as the most frequent ones overall. And indeed, the most frequent type of infections were identified as pneumonia or lower respiratory tract infections, followed by urinary tract infections, surgical site infections, and bloodstream infections. If we also reflect on sepsis had a longer length of stay and high AMR rates, both factors significantly impact on patient outcomes. According to this study, the mortality of patients affected by HAI sepsis was around 24%, but this increases to more than 50% in ICU-treated patients. And the median length of stay of patients affected by healthcare-associated infection sepsis compared to community-acquired sepsis was 2 to 3 times higher. And up to 1/3 cases of healthcare-associated sepsis were caused by drug-resistant bacteria, which is more or less indeed also the proportion of HAIs which are caused by drug-resistant microorganisms. So if we continue to reflect on mortality, again, talking about the data that were issued last year and also previously in 2019 about the mortality or the number of deaths worldwide associated with AMR, which were about 5 million. We should consider the proportion, even if it's not part of the same study, but the proportion of these infections, these deaths that are actually also due to HAIs. And according to this recent study by WHO and OECD, which is in part published in our global report and will be further published in the investment case document, which will be issued next week. 3.5 million deaths are some way linked to healthcare-associated infections worldwide, according to WHO and OECD. And the impact in terms of costs that my colleague will certainly detail later is estimated to be 505 billion in health costs and more than 660 billion in productivity losses. But as I said, my colleague will go more into the details on this aspect. So far, I talked about the aspect of the burden and the harm caused by HAIs and gave you a quick overview of some of the most important pieces of data that we presented in the global report, and also will further be detailed with some new pieces of data in this investment case document that will be issued next week. But as I said, the second element to advocate for more investments in IPC is to look at what is the situation in terms of our progress, also considering we just have come out from a pandemic, our progress in implementing IPC interventions and programs. And again, you can find this data in the global report issued in November 24. So first of all, I would like to say that the data that we presented in this report come from different sources, and often they are very much aligned, even if these belong to different sources and surveys. And as you know, WHO gathers data on AMR and antimicrobial use through the GLASS system, and also data about implementation of actions to reduce AMR through the tripartite antimicrobial resistance country self-assessment survey. We also collect data on the IPC capacity at the national level through the ESPAR, which is a system to track capacities that are critical for international health regulations implementation, meaning outbreak response, preparedness and response. And also there is a joint monitoring program by WHO and UNICEF for WASH in healthcare facilities. So some of the data that I will present come also from this system. In addition, the core of the data that we presented in this global report and that we then further analyzed and we hope to issue also in a scientific, in several scientific papers, come from a global survey that we conducted in 23-24 using the WHO IPC portal, which is a resource through which countries can submit their data in a confidential manner and with a lot of security ensured. and they can also download a report and also download some guidance from WHO in terms of which tools are available to improve their level of progress depending on their score. So through this portal, we conducted a global survey, which was then the basis for the global report. And the global survey uses assessment tools for assessing the IPC core components that WHO recommends at the national and facility level, as well as the so-called minimum requirements, which are derived from the core components, but are a bit a lower level of requirement than the full core components. And they are considered the standards for achieving a minimum level of protection of patients and health workers from infections and from AMR. So these are the type of data that I would like to present, and also these are the tools that are associated with the surveys, and you can all find them on the WHO web pages if you are interested in using them. So starting from the tripartite AMR country self-assessment survey, this is a national level assessment of IPC programs, and there are 5 levels from the red, which is obviously the least implemented, and to the dark green, which is the best level of implementation of IPC programs. And basically we go from no IPC program or operational plan in the country to having this plan but not having it implemented. The C level is implementation, but only in selected healthcare facilities. And the light green is a level of implementation nationwide, but still there is no evaluation and monitoring of compliance with the national standards and the effectiveness of the IPC program, which is instead the highest level of progress, which is E. So if we look at the trends over 7 years until last year, in terms of the distribution of countries, in this graph, you can see from 2018 to 2024, there has been a slight improvement over time, especially in the last couple of years, starting from 21, which was actually the second year of the pandemic. So certainly there has been an impact in scaling up IPC programs during the pandemic. So there has been an improvement, but this improvement, unfortunately, mainly pertains to countries which are advanced in the 2 green levels and less in the other levels. So it means that really there are a number of countries which still need to progress significantly across at least the intermediate level, let's say. And in fact, in the 24 survey, there was a 93% of countries reporting to have a program and a plan, but only 44% had a dedicated budget for IPC, meaning that even if they declared that they had a program, probably that program was not very active because in half of them there was no budget available. And overall, only 38% of countries were able to implement IPC programs nationwide, and also a minority of them were able to have a monitoring system to assess the effectiveness of this program. So this is according to the aggregated data. If we look at the level of income, according to the same data in 2024, you can see that there is a clear difference between high-income countries and upper middle-income countries versus lower middle-income countries, and especially low-income countries, where the number of countries that are in the most advanced levels are only a minority. So this graph, as well as other surveys, really highlight the disparity, once again, across levels of income in terms of the capacity of countries to have an IPC program and activities in place. Similarly, if we look at the data over time from 21 to 23, coming from the other system I mentioned earlier, the IHR implementation assessment system, specifically for the IPC capacity or component, which is related to outbreak preparedness and response. The orange line is reflecting the global situation. And you can see that over the years, it didn't change very much. So there hasn't been a real improvement over time, a slight improvement in 22, but then in 23, the average score came back to the more or less the same level as before. And then in terms of distribution across continents and regions, you can see that once again, the African region has the lowest level of IPC capacity for outbreak preparedness, whereas the European region has the highest level. The other element that we can see is that some of these regions clearly had an improvement between 21 and 22, but then there has been a fall in the average score to lower levels, or even levels that are lower than 2021, which means basically indicates a disinvestment in IPC interventions and programs as the pandemic went down. So this is quite sad to see, and this is why we have to continue to do a lot of advocacy. And I hope that recent initiatives, which I will mention in a moment, will help us elevate IPC again in the global agenda after the pandemic, and hopefully also building upon the lessons learned from it. So the next data are data coming from 150 countries at the national level, and about more than 5,500 facilities from around the world. In terms of fulfillment of the minimum requirements for IPC programs. And they come from the global survey we conducted between end of 23 and end of May 24. And they are, as I mentioned before, the data are documented within the global report. First of all, however, I would like to remind you with the situation in terms of some of the WASH indicators that were reported last year in the latest WHO UNICEF report coming from the joint monitoring system that I mentioned earlier, which show us that in terms of availability of basic water, meaning clean water, and also available within the facility, 1 in 4 healthcare facilities lack these basic water requirements, and the corresponding population that is served by these facilities which lack basic water is as high as 1.7 billion people who access care without being able to receive clean water and the services associated with it. Similarly, 2 in 5 healthcare facilities lack basic hand hygiene supplies and facilities at the point of care and toilets in healthcare facilities, as I said. So again, these are very alarming indicators about the safety of the care delivered in these facilities. So the results of the global survey that I mentioned earlier, the overall results are very alarming as well. In terms of the proportion of countries that fulfill all the minimum requirements for IPC programs, it's only 6% at the national level, whereas at least 90% of the minimum requirements are fulfilled by 14% of countries, and 80% of countries fulfill at least 50% of the IPC minimum requirements. At the facility level, the situation is also quite alarming, although less serious. With about 16% of facilities fulfilling all the minimum requirements, 21% fulfilling at least 90% of the minimum requirements, and 75% fulfilling 50% of the minimum requirements. Just as a comparison, in 2019, we were able to estimate also the fulfillment of the minimum requirements through another survey, and the situation really was very similar. So there appears not to be a major change at the national level. About 4% of countries were fulfilling all the minimum requirements, and 15.2% of facilities were fulfilling the minimum requirements. If we go a little bit into the details and we look also at the strengths of the IPC programs around the world, because obviously there are also positive things to be said, especially according to the latest survey that I mentioned. The core components which are most implemented are guideline development, which we know is something usually countries can state they have or they are doing. And the indicators related to this were quite highly reported in a positive way, such as using evidence-based scientific approaches to develop guidelines and also addressing local adaptation. So these are all positive aspects linked to guideline development. And the new aspect, which we were very pleased by, was a strong improvement in the fulfillment of the recommendation that WHO made among the core components to use multimodal improvement strategies, which are ways of implementing IPC interventions at the point of care to reduce the most prevalent infections depending on the local situation. So this core component was scoring quite poor in the past. And now we have seen an improvement. For example, 75% of countries reported that they have trained IPC focal points who promote multimodal strategies from the national program down to the facility level. And therefore, this has been a very positive shift from the past, where multimodal strategies were not easily understood. Aspects that instead are still appearing having a low level of implementation are related to budget allocation. As I said, less than half of countries have a dedicated budget, and in low-income countries, only 33%. Training and education is one of the lowest implemented core components, also in previous surveys. Again, this pertains especially to implementation of training and education, providing resources to facilities or training people at the national and facility level in reality. So, for example, only 38% of countries reported to have a national IPC curriculum, which means that they even don't have the basis for then delivering training. And of course, other two elements or core components that are defective are HAI surveillance and monitoring and evaluation, as you can see in this slide. Again, with only half of the countries that had a multidisciplinary technical group dedicated to HAI surveillance. And this is only in 25% of countries in low income level. This doesn't even mean to have a system for HAI surveillance, which occurs certainly in a lower percentage of cases. Similarly, the situation related to monitoring and evaluation is suboptimal, with only half of the countries, again, having a strategic plan and a system for IPC monitoring, and having low-income countries less advanced than high-income countries, although here the score is higher in low-income countries compared to the HAI surveillance type of indicator. At the facility level, we have already discussed about the fulfillment of the minimum requirements. You see this represented in a different way compared to the previous slide. And this helps us appreciate once again the disparity across the levels of income, in particular having upper middle income countries and high income countries with a higher ability to fulfill the minimum requirements compared to the two other levels. In particular, in low-income countries, there is a limited implementation of basically almost all the core components, even if some of them, for example, implementation of multimodal strategies was scoring better. And also, in particular, in indicators related to the availability of IPC professionals, allocated budget, availability of routine microbiological laboratory support, and having appropriate workload, staffing, and bed occupancy were all indicators which were scoring in a defective way in low middle income countries. And finally, this is a survey conducted between 23-24, coming out from a dramatic pandemic, and still we got very worrying data related to the availability of sufficient PPE in facilities that participated in the survey, where only, for example, 66% of primary care facilities were reporting to have sufficient PPE. And again, with significant differences across levels of income. So the last point of my presentation is about what is the gain we can have in implementing IPC interventions in terms of the parameters we just talked about, the frequency of HAIs and also the burden. So there have been various also recent publications. One is an important one within the Lancet series published last year, where researchers conducting modeling studies related to AMR associated deaths in low middle income countries were reporting that having IPC standards in place and access to WASH services could prevent around 600,000 deaths in low middle income countries. And this is an important point because you may know that one of the global targets related to AMR is to reduce global AMR-associated deaths by 10% by year 2023. And considering that the global deaths associated with AMR are about 5 million, as I mentioned earlier, this target would be achieved only by implementing interventions that are already available, proven to be effective, and these massively include, indeed, IPC standards and WASH services, as well as the use of vaccines that are available to prevent some bacterial infections that are antimicrobial resistant. So this is an infographic that is available in the new investment case document that will be issued from WHO next week. And we summarize a number of pieces of data. Starting from the bottom, you see the Lancet data that I just mentioned. And then in general, according to different studies and reviews, we know that from 35 to 70% of HAIs can be prevented. And also, when we combine interventions, including IPC, but also antimicrobial stewardship, apparently these two approaches reinforce each other and can reduce the burden of AMR by 85% in some reports, according to some reports. And the top pieces of data and image that you have here come from this WHO and OECD study that we just concluded and we are publishing. Which, as I said earlier, estimated that 3.5 million deaths occur every year up to 2050 due to HAIs. And we can reduce them by preventing 821,000 deaths every year by implementing interventions, in particular a specific type of intervention that was modeled in this study, which is implementing multimodal strategies at the facility level to reduce targeted HAIs, but also having that approach supported by national or subnational coordination, meaning that when there is a national initiative to reduce HAIs at the facility level by using multimodal strategies, this is an approach that is the most effective, even compared to the simple implementation of multimodal strategies without having a national or subnational coordination or network. So these are important pieces of data that we can also further reinforce with the data that you see on the slide coming from this unpublished study that I just mentioned, and where you see that the light blue bars correspond to the intervention I just mentioned, implementation of multimodal strategies at the facility level, supported by a national or subnational coordination. And you can see that this is the highest impact intervention in terms of reducing annual mortality rates associated or attributable to HAIs, and this is particularly effective in low-income and low-middle-income countries. You can also see that the highest impact is in African countries, where indeed we saw before the burden was the highest as well. So there is an impact, especially where the burden is highest. I'm about to conclude, but the slides are still very slow. Apologies. And in fact, there are important documentation of implementing this type of interventions that you can find in the literature, which are cited in our documents. But one in particular, you can find a case study, a country case study in the Global Report, which is about the Saudi Arabia National Initiative to reduce CLABSI, by using multimodal strategies and having a national initiative, as I mentioned earlier. I'm just waiting the slides to move. Apologies again. A last piece of data on effectiveness comes from another study we did during COVID-19 pandemic, where again, a specific type of intervention, which was combining increased access to PPE and scaling up IPC education and training in the first 6 months of the pandemic, demonstrated that we could have averted almost 10 million new infections in health workers. And you see in the graph that this would have corresponded to averted cases, averted hospitalizations, ICU admissions, and also averted deaths among health workers if we had PPE in place and also education to be scaled up rapidly at the start of the pandemic. So in conclusion, I wanted to remind ourselves that all these data are have been the basis to convince member states and countries around the world to adopt a global strategy and a global action plan for improving IPC between 2024 and 2030 across the entire continuum of the health system, with the vision that by 2030 everyone accessing or providing care is safe from associated infections. Within this global action plan and monitoring framework, we have 131 indicators and 27 targets which were identified through a Delphi study. But in particular is notable that there are 8 core or top targets and indicators at the national level, which will be measured at the global level in terms of increase of proportion of countries between 2024 and 2030, with a costed and approved national action plan and monitoring framework, a dedicated budget for IPC, legislation and regulations, achieving all the minimum requirements at the national level, and progressing across the levels in the systems measuring capacity that I mentioned earlier. Increase in the proportion of countries with basic water, sanitation and hygiene and waste services in all healthcare facilities, and with national HAI and related AMR surveillance systems, and having achieved a national target on reducing AMR. Similarly, there are 4 top targets at the facility level that countries adopted and will work towards. And these are similar in terms of the type of indicators, apart from one that is related to providing or requiring training at the facility level for all frontline clinical and cleaning staff and managers. So this is what we aim to all together, and countries accepted the challenge to progress from 24 to 2030 and increase the proportion of countries and facilities that should go up to 80% or 90%, depending on the indicator and target, fulfilling, as I said, those targets. And so it's a very ambitious project, but I also think that it is feasible, considering the strong evidence that we have. And I would like to conclude by telling you that in the global report, we also, in the last chapter, which is related to the way forward, we also provided what is the baseline level for some of these indicators that are have become global targets for infection prevention and control. You will be pleased to see that some baseline data are actually quite in line with what we hope to achieve, for example, by 26 or by 28. And so the miles to be made are depend on the type of indicator, but in some cases the progress should be relatively easy, and in other cases, such as the fulfillment of all minimum requirements, will be very challenging because, as I mentioned earlier, we are starting from very low levels of fulfillment of the minimum requirements at the national and facility level. So I would like to conclude by saying we do have our tools. Also, we have powerful policy documents now approved by all countries that are members of WHO last year. But we certainly need more local investment and also implementation. We need leadership and advocacy to make this implementation possible. And of course, for this, we need financial investment. But also, we need to strengthen monitoring of improving that there is progress or highlighting where there is no improvement of these indicators that we all agreed to accept and work towards. With this, I would like to thank you, and I would like to now move to my colleague, Michele Cecchini, and back to Martin for the aspects of the economic case.
Thank you very much, Benedetta. As you say, there has been some progress, certainly no cause for any complacency whatsoever, and a long way to go yet, I think, for many countries. We're now going to move on to looking at the cost of healthcare associated infections in AMR and looking at the economic case for investing in IPC. And it's my pleasure to, as Benedetta has said, introduce Michele Cecchini, who is the head of public health at the OECD, based in Paris. He's actually a medical doctor by background, and then he got interested in the economic aspect, did his PhD in health economics in Imperial College in London. He's head of the Public Health Organization for Economic Cooperation and Development, OECD, in Paris, where he and his team were looking at priority setting and program evaluation of policies affecting population health. He's an adjunct professor of applied health economics at the School of Public Health at the University of Siena, and is a visiting professor in the Duke NUS Graduate Medical School in Singapore. So welcome, Michele, and looking forward to listening to the economic case, which is going to be vital, I think, if we're going to get investment going forward.
Thank you very much for the introduction. It's a real pleasure to be with you all today. And let me also thank the organizer of today's webinar, but also my colleague Benedetta Legranzi for extending the invitation to the OECD and to show some of the work that over the years my team and her team have been doing together. So in the next 20 minutes or so, I'm going to present you some of the results of this joint work and activities together with WHO and the IPC Hub, and in particular the economic aspects. We all know that to mobilize resources and to go ahead in terms of implementing innovative policy options, but also gold standard for when it comes to infection prevention and control, mobilizing resources is a fundamental aspect of the work. So most of my discussion will vert on that, but we shouldn't also forget that healthcare-associated infection cause a significant burden on the health of persons. So in this joint work with WHO, we have calculated what would be what is the health burden of hospital-acquired infection, and we came to the conclusion that between 20 and 80 deaths per 100,000 persons are amenable to this burden, to hospital-acquired infections. Now, to give you a sense of the order of magnitude of what we're talking, I've tried to compare it with other significant causes of disease that usually are more cited than hospital-acquired infection. And if we take respiratory diseases, upper respiratory infections, lower respiratory infection, and tuberculosis across G20 countries, we see that roughly the order of magnitude is the same. So hospital-associated infection cause a mortality burden that is in the same order of magnitude of upper respiratory tract infection, lower respiratory tract infections, and tuberculosis. So we are talking about a significant cause of burden on human health across countries in the world, with some countries, particularly countries at lower level of income, that bear most of this burden. But as I pronounced, there is also an economic cost. We calculated the economic cost by looking at what very often is referred to as extra health expenditure, the direct cost. And here is the light blue part of the graph, and what instead very often are called indirect costs, which we prefer to call productivity losses because we believe that are very direct consequences of HIAs. How we calculated this? We looked at the extra time that people spend in hospitals, for example, due to the complications caused by hospital-associated infections, but also the time that these persons cannot go to work. So we calculated a reduction in productivity in terms of absenteeism from work. People that stay in the hospital are not back as active member of the workforce. In some cases, due to HIAs, they develop complications, and these have long-term consequences. And in some cases, they have, for example, to retire earlier from the workforce. Finally, people that die due to these infections clearly are not part any longer of the active workforce. So when we put all these dimensions together, these are the number that we see. We see that between $50 at purchasing power parity per capita to more than $600 PPP per year are spent by countries to deal with the consequences of this type of infection. When we put all these numbers together, we calculated that the cost is almost 1.2 trillion PPP, which is in the same order of magnitude of the GDP of Colombia. If we just focus on the healthcare expenditure, then the cost is almost half, is 0.5 trillion PPP. And again, to give you an idea of the order of magnitude, we spend on HIIs almost the health budget of France per year. So we are talking about also not just a significant health burden, but also a significant economic burden. In the aftermath of COVID-19, we have also started discussing how we can increase the resilience of our healthcare systems. Clearly, our healthcare systems were not completely up to speed to deal with a peak in request of, for example, intensive care unit, hospital beds, to deal with persons that had developed COVID-19, but also in the post-COVID-19 and before COVID, so outside the COVID period, we know that in many countries there are very long queues to get access for the treatment of, for example, chronic diseases. Part of this reason is because we use hospitals to deal with the consequences of hospital-acquired infections. We calculated that almost 1.8 billion extra days of time spent in hospital are used every year to treat the consequences of hospital-associated infection. Clearly, if we could get rid of this infection, we would be able to ensure a much more rapid turnover in the utilization of hospital beds, but all in all, we would also increase the resilience of our healthcare systems. One of the duties that I was given was to explain a little bit the rationale and how we have carried out this analysis. And that's what I'm going to do in the next few slides. To do this analysis, we adapted our SFAP model, where SFAP stands for Strategic Public Health Planning, to carry out analysis for this type of infections. This model is a microsimulation model in principle, meaning that it replicates the life path of people in a virtual environment. In this virtual environment, we can replicate by feeding data on demographic, on risk factor profiles, on the epidemiology of diseases, on healthcare expenditure, and labor market outcomes. We are able to replicate what happens in the real world over a period of 2023 and 2050. We have recreated 17 regions in this world, which are created with a combination of WHO region geographical division, so the 6 WHO region, Europe, Africa, America, Middle East, Southeast Asia, and Western Pacific, as well as income level from the World Bank. We feed the model with all the various parameters, and we have people that live, virtual persons that live their own life from birth to death over the period in the model. Of these persons, we are able to track everything: the diseases they develop, their health outcomes, how much they spend, if they have access to healthcare system, what is the productivity, and we can also use this data to calculate the gross domestic product of the country, as well as the fiscal pressure of the country. Specifically for this joint project with WHO, this is a representation of the module representing hospital-associated infection. Clearly, I'm simplifying the structure and the data used to feed this module, but this should be enough to give you a good sense of how we carried out the analysis. So we start from individuals in the community. These are persons that may be in good health, or they may have, for example, chronic diseases. Because of any reason, this person, at a certain point, they may have access to a hospital. Once they are hospitalized, they may develop or not develop an infection. And in the case, if this infection is developed, we select whether this infection is susceptible or resistant to antibiotics and the site of infection. This infection can take place, for example, after a surgical operation. It can be at the lung, it can be urinary tract infection, it can be at the skin, it can be of different nature. We also have implemented into the model specific health outcome trees that replicate for each type of infection what would happen to this person developing the infection, including, for example, the long-term sequelae. Certain types of infection can produce a health status that remain chronic for the rest of the life of these persons. Due to these health outcome trees, the person may stay longer in the hospital, and if this person develops a particularly difficult situation, doctors may decide to move this person from a hospital bed into an intensive care unit. Clearly, this triggers different use of resources, different costs also for the healthcare system. Persons at the end of this process, they can die due to an hospital-acquired infection, associated infection, or they may be dehospitalized and they can die also for another cause that is not directly linked to the hospital-associated infection. If they are dehospitalized, even if they have long-term sequelae, they go back to the community and they continue their life until they may or may not re-enter in the hospital. If they re-enter in the hospital, the process starts again, so the person can develop a new infection and so on, until at the end of the process, they die either because they have general mortality or because the simulation stops. This allows us to follow this person throughout their life, but also allows us to test different scenarios. One scenario that we test is the one to calculate the burden. So we run the model twice, one in the business as usual, and one assuming that persons that are hospitalized, they never develop an hospital-associated infection. The difference between these two scenarios allows us to calculate what is the burden of the infection. Or it also allows us to test what would be the impact of scaling up different types of intervention. For this very specific analysis, we have tested two interventions that are based on the WHO core component and best practices for what concerns infection prevention and control. The two interventions are multimodal facility and an enhanced version of the multimodal facility intervention that we call multimodal facility plus. These two interventions have the same type of activities at the hospital level. These are those that Benedetta mentioned in her presentation. The main difference between the two interventions is that in the plus version, there is also some coordination and some action at the subnational or the national level to better implement the facility level intervention. Based on a systematic review and meta-analysis that was commissioned by WHO, we concluded that the impact of this two intervention is in the case of the facility versus the business as usual, the risk of infection decreases by 27%. So the relative risk for developing an infection is 0.73. with a confidence interval between 0.63 and 0.85, while for the more effective intervention, the relative risk is 0.69, meaning that the more effective intervention further decreased the probability of developing an infection by 4%. We also looked at the level of implementation in the current situation of this intervention. And now I'm referring back to the slide that Benedetta showed. Across the regions, it's between 3.4% and 34.5% for the facility. And it's almost half, and that's based on expert opinion, in terms of the more nuanced, the more effective intervention. We also set a target. So from the current condition, from the current situation, we wanted to reach a coverage of around 80% of all the hospitals that are covered by the intervention. And we assume that once the intervention is scaled up, meaning it's implemented intervention, the effectiveness remains constant over the whole simulation period. Meaning that there is a continuous implementation of the intervention until the end of the simulation. To give you a sense of the order of magnitude of the effort that countries need to scale up, here is the coverage of the increasing coverage of IPC intervention from the current level to the 80% target by assessed region. In particular, on the left axis, we have the gap to the target. So, for example, if we take upper middle income and high income countries in the African region, they need to increase the coverage of this intervention from the current level to they need to increase by around 63-64%. While on the right axis, and that's the diamond, we have the order of magnitude which they needed to increase the coverage based the current level. So again, for African region, upper middle income countries and high income countries, they needed to increase by about 5 times compared to their level of the current level of intervention. In some cases, you can see that we need a substantial increase in terms of implementation level, almost 20% times in few cases. Generally speaking, countries at higher level of income, they tend to have reported higher level of implementation in the business as usual in the current scenario. Therefore, the efforts need to be smaller compared to other countries. And this is what we calculate would be the impact of scaling up these interventions at the desired level, meaning 80% of healthcare facilities have in place the intervention. We calculated that multimodal and multimodal plus can prevent respectively 20% and 25% of the hospital-associated infection deaths. And we are talking fundamentally about a significant amount of deaths that can be saved by scaling up this intervention. In general, countries that are low middle income and lower income countries are those that see the highest saving once we adjust for age in terms of mortality. When it comes to the economic impact of these interventions, we see that the total gains, meaning both healthcare and productivity gains, can be saved in the order of magnitude of 171 billion and 236 billion US dollar are purchasing power parity for these two interventions. Again, as we saw for the cost, a part of the savings comes from productivity gains, and another part of the gains are instead amenable to saving in healthcare expenditure. Trying to put IPC in the context of the fight against AMR. You are perfectly aware that last year in September 2024, there has been the UN high-level meeting on antimicrobial resistance in the context of the UN General Assembly. Countries committed to put in place policies to reach some of the targets that countries have decided to aim to achieve. In this context, we think that our analysis make a strong case for infection prevention and control to be a low-hanging fruit in the fight against antimicrobial resistance. Hospital-acquired infection are the main target of IPC and account for around 3 in 5 deaths from antibiotic-resistant infection. Infection prevention and control reduce both resistant and susceptible infections and deliver results much faster than many other interventions that can help countries achieve the targets on antimicrobial resistance. In addition, they help us buy time to invest in stewardship and research and development to produce new antibiotics, to put on the market new antibiotics. Finally, infection prevention and control have a particular impact on those that are most vulnerable in our population. For example, newborn and hospitalized patients that are very often also elderly patients. So there are a number of win-win-win that infection prevention and control can deliver for countries in achieving the AMR target. And it's not surprise that they are a fundamental pillar of the One Health package of intervention that is mentioned in the UN resolution on AMR as a potential way forward to tackle antimicrobial resistance. We calculated that we need to invest to target antimicrobial resistance, $52 billion at PPP per year. Which represent around less than, in fact, 0.5% of what we spend on health globally. So we are not talking about an enormous amount of money if spread at the global level and when compared to what we already spend on healthcare. The priority intervention part of this package are WASH, water and sanitation, infection prevention and control, stewardship, and research and development of new antibiotic. In particular, if we look a little bit at the pie chart on the right, we can see that interventions such as hand hygiene account for a very small part of the total cost of $52 billion. We're talking about 1.6% of the total cost. The package will pay big dividends by significantly reduce adverse health and economic impact of AMR. And finally, the package generates a net return of investment, which is approximately $10 for every US dollar invested in the package. Infection prevention and control is also very helpful in ensuring the resilience of our healthcare system. I already mentioned at the beginning how much we could save in terms of days spent in hospitals due to a better implementation of infection prevention and control policies, but also in the context of outbreaks, of epidemic outbreaks, better infection prevention and control can maintain a healthier and more functional workforce. This is another analysis that we have again carried out in collaboration with Benedetta team in the aftermath of the COVID, and we looked at the return on investment of combined increases access to PPE, personal protective equipment, and IPC education and training. And we looked at what would be the probability that investing in this intervention would be cost effective across 7 regions in the world. And in particular, we saw that in the case of enhanced hand hygiene, in 40% of cases in the context of SARS-CoV-2, so I'm talking about in the context of SARS-CoV-2, not bacterial infection or other types of infection, enhancing hand hygiene alone would be cost saving in 40% of the cases, would be cost effective in another 40% of the cases, and would not be cost effective in 20% of the cases. Increasing access to PPE would be cost saving in 75% of the cases and would be cost effective in an additional 10% of the cases. But when we combine the two interventions, they together, they would always be either cost saving or cost effective, and in almost 90% of the cases, they would be cost saving intervention. So very good best buys in terms of preventing, of saving lives and preventing healthcare personnel from falling sick in the context of an epidemic outbreak. So what are the policy implications of my presentation? The first one is that hospital-associated infection impose a significant health economic burden on countries across all income levels. Effective strategies include infection prevention and control training and education for healthcare staff, promoting multidisciplinary collaboration, fostering strong leadership and a culture of safety, all supported by a robust surveillance and feedback system. I'm talking about multimodal intervention here. And even better, if there is a strong coordination from the national or the subnational level. Number three, we see that, however, substantial efforts and investment are badly needed to ensure predictable and sustainable resource mobilization and the scaling up of infection prevention and control practices that work best. Too often we see, and I think that the results from the WHO survey on this are very, very, very clear. We see that the implementation of this intervention is jeopardized and too many facilities are not investing enough in ensuring the implementation of this intervention, and when this intervention is implemented in its gold standard. Scaling up APC can significantly reduce the burden of healthcare-associated infection by up to 25% and enhance the resilience of healthcare system by both increasing the turnover in the use of hospitals, but also keeping patients and healthcare personnel safe and free from diseases. IPC can also play a critical role in our fight against antimicrobial resistance, improving the resilience of health services during the epidemic outbreak. I stop here. I thank you very much for your attention.
Thank you so much, Mikhail. That was amazing and frightening in some ways, because if healthcare was an industry, as in a company, you would look at the return on investment. You mentioned the low-hanging fruit. For every $1 you spend, you get $10 back. If this was a business, the chief exec would say, we've immediately got to do that. So why can we always struggle to make the economic case when it's very obvious that investment would save A, money, B, lives, and C, antibiotics for our future use? Is it because it's not seen as a business, it's seen as a service, if you like, healthcare, and therefore doesn't hit the priorities at national level?
Shall I respond? Benedetta, you want to have a go? How do we want to handle this?
No,
You can fight over it.
you can start, Mikhail, if you would like.
Absolutely.
I have to say as well afterwards.
Okay. You're perfectly right, and that's something that as OECD, but also as WHO, we are pushing a lot on this economic case. There is a clear economic rationale for doing this. Why are not we doing this enough? Many different reasons. In some cases, it's because the system is not designed in the best way. In many other cases, it's because it requires an investment at the beginning, and healthcare budgets are too often, particularly in low and middle income countries, already stretched by other reasons, and it's difficult to carve out, to put aside the budget to start this type of intervention. What we think is a way to move forward is to put the right incentives in terms of, for example, payment of certain the functioning of hospitals. So to create also an incentive for the healthcare structure, for the healthcare service to implement these interventions.
Thank you.
Benedetta, you want to continue?
Yeah, just a small addition, which is much less insightful, I guess, and critical than what Michele said. But I think that, to be very honest, until now, I haven't seen very strong data also broadly disseminated on this topic. Because, as you know, there are some cost-effectiveness studies. There are also reviews of cost-effectiveness studies, which have been published recently. But I have to say, also from the WHO perspective, we started a few years ago this piece of work because we thought it was really important to demonstrate this case, especially the economic case. But then we were slowed down by the pandemic. I think we now are in a new phase where I think it's quite unprecedented that this data that we presented today will be disseminated and issued. I'm not aware that there is any other global study available, also with the stratification by region and level of income. So I'm pretty sure that what we are going to publish in the next months will be quite new and hopefully ringing many bells to attract attention. The other point, I guess, is that ideally there should be ability to conduct analysis for investment cases tailored to the local situation. So we think that this should be a priority for countries, for governments, for ministries of health. And actually, this is included as one of the critical actions in the global action plan that all member states adopted. So there was some way a recognition that it's important to make this analysis at the country level to have data related to their own reality. So hopefully there will be a new phase in which this new data provided by WHO and OECD in the next months will ring bells, will help people understand and see real numbers, and then hopefully also countries doing their work to do this type of assessment.
Okay, thank you. And just one last quick question. In that, given that it's the lower middle income countries that have the highest rates of healthcare associated infection, and yet they have also the furthest way to go in terms of opportunities for improvement, what role can international collaboration play in helping these, even out these disparities? Is there something that the higher income countries can do to help their colleagues in lower income countries?
Yeah, for sure. There are possibilities and there are also very good examples. Again, you give me the opportunity to mention that there is another country study in the global report, which is about Nigeria, where Nigeria over the last few years really incredibly progressed their level of in-depth of the IPC program nationally, but also the implementation at the facility level. And this was thanks to the fact that they were able to attract attention from high-income country governments at the time. For example, a lot of the US support to in the context of international cooperation, but also other countries supporting their own global national plan for IPC. So I think that what is needed is, one, to have low and lower middle income countries focus their attention in terms of the national health agenda on this topic, showing commitment, showing serious engagement to achieve improvements, able to formulate their requests and their calls according to their needs, well articulated in a national plan. And at the same time, international organizations or cooperation organizations from high-income countries, governments, to buy in. When these two elements, I would say, exist, then there are very interesting models and also very interesting experiences and examples of progress that we can document. And actually you can find also, for example, in the 2022 global report that we issued, there are many other examples. We also have a web page where we document success country examples of all income level, but there are some which are low and lower and middle income level. So there are good opportunities.
Thank you very much indeed. Well, I want to thank both of you for a fascinating session. The recording will be online. If you want to highlight the session to your colleagues around the world who've managed to miss today's session. I'd just like to also highlight the Teleclass education topics coming up over the next few months, but in particular the one on the 20th of March, which is Frugal Innovation for Low Resource Settings with Professor David Biagio from the UK. So thank you very much for joining everybody today, and thank you to the Teleclass Education patrons, sponsors as ever, without whose support Teleclass Education would not be possible. That's Diversity, Virox Technologies and Gamma Healthcare. Thank you very much for joining us, everybody. We've really enjoyed the session and have a very good day.
Thank you very much as well to you, Martin, and to Paul Weber for hosting us. Thanks a lot for this incredible opportunity as usual.
Thank you very much also on my side. It was very enjoyable.